Good morning and welcome. Today, I believe, is the fifth day of this amazing convention put together by innovative, creative, and pace-setting faculty of the University of Port Harcourt Teaching Hospital, School of Public Health. My name is Obinna Oleriben, and I'll be addressing this September audience on this topic today: what is your why? I schooled here several years ago, the 1987 sets, finished 1995, and I'm a proud alumnus of the school. And over the years, one of my greatest right decisions was coming to this school to be a student, and today to talk to you on this amazing conference. I'm glad you're here this morning. I'm glad you made the choice to come, and I'm glad you're learning, because I strongly believe that this conference will leave a mark in your personal life and also in your career endeavors. Sorry. The theme of the conference is Translational Research for Improved Service Delivery and National Development. And I have been given the onerous task of looking at a sub-theme, Equity in Healthcare Delivery in Changing Disease Landscape. I believe that it's not only the disease landscape that is changing, the entire world of public health is changing, particularly with the evolution and revolution being caused by AI globally. But tonight, I will not focus on AI, even though that is my current area of interest, and we can talk about that maybe some other time. But today, this morning, I want to focus on what is your why. This simple question defines my full presentation today. Why did you choose this program? Why did you decide to attend this particular conference? Why are you here today on this fifth day in a program created by the faculty and students to showcase research achievements of the students and faculty of a very pioneer school of public health in Nigeria? Over the past 4 days, I believe you have heard from distinguished faculties, respected professionals, and thought leaders who have illuminated crucial topics across public health and epidemiology. Today will not be different. Following my session, you will engage with experts in environmental health, population, and reproductive health. You will also look at community health, public health nutrition, health promotions, communication, and occupational health. The conference is really, really rich. Throughout this conference, friends, you have learned and will continue to learn from individuals who have made enduring and lasting impact on public health space. From those striving to make that difference, and from those who have sacrificed greatly to move public health from where it used to be to where it is today. I truly count myself to be among the last group. Those who have paid personal price to follow a calling. After graduating from this medical school in 1995, my mentors envisaged me as a surgeon or obstetrician, or at least an internist. Fields they believed held the highest respect and financial reward. But I chose a different path. I chose public health. And I chose it with intention. So I ask you this morning, what is your why? I became a doctor because my father wanted me to be. I suspect some of you have similar stories. My own dream was to be an aeronautical engineer, to build my own plane and to fly it. I actually got admission to study aeronautical engineering. at about 29,000 pounds at that time. But since my parents couldn't afford that amount of money, my father encouraged me to do something different. I decided to go for electrical electronics engineering, which I thought was close to aeronautic engineering. But then a single letter from my father changed my trajectory. So I set aside my personal dreams to fulfill my father's deep wish for me to study medicine. Even after his passing during my first semester here at University of Port Harcourt, I carried on with that promise, studying relentlessly, investing my energy, and striving to be the very best in my class and my profession. When it came for me to decide where to spend the rest of my life, a specialty, I told my devoted teacher something that at that time felt bold and maybe arrogant. I said, one day, public health will be the field every doctor and healthcare professional will want to be in. Today, we are living in that very reality because surgeons, gynecologists, everybody is running to do public health, MPH, DRPH, PhD, because they understand that without public health concepts, you are myopic, you will not go too far in the current space. But why did I choose public health? One day, while undertaking my clinical postings in town as a medical student, a child was brought in for routine circumcision. What struck me was not the procedure, but his journey to the hospital. He had come from a prison here in Port Harcourt. He was born dear to an incarcerated mother, and after the circumcision was to be taken back to prison. I found this unconscionable. I was angry, very angry enough to write my first article, Prisoner from Birth, in the Daily Sun newspaper. That article surprisingly earned me an invitation to the government house for questioning, but it also became my aha moment when I realized that we can and we must do something to end all forms of child abuse and child neglect. So, while in medical school, I began to take steps. That moment gave birth to several non-profit, beginning with the Anti-Child Abuse Society of Africa, ACASA, which many people know me by. From ACASA came books such as The Concept of Child Abuse and The Fundamentals of Child Rights. ACASA also gave birth to other non-profits since then. When a woman accused me of not caring for the family because a child cannot have a healthy life outside the family. So I formed the Center for Family Health initially as a hospital, and then the initiative as a non-profit. And also when I began to run HIV program and grants, I founded the Excellence and Frame Management Care Center in Abuja and several other initiatives. Through trainings, meetings, and conferences like this, I discovered the immense power of policy, the impact of empowering individuals, that's the people, and the transformative role of government politics in addressing people's problems and needs. At that point, friends, choosing public health, which is a process, was no longer a question. It was the only logical option. So let's get to today's topic, equity. Equity in healthcare delivery in a changing disease landscape. Understand this, friends. We are gathered here today under this theme. There can be no true equity in healthcare until we first understand what equity truly means. Long before equity became the new flag to wave, I had already been on the front line driving equity here in Nigeria. I founded ACASA with one driving mission: to ensure that every child received equitable services, no matter their background or circumstances. And I started EFMC in Abuja to ensure that everyone diagnosed with HIV received equitable care and treatment. When children with anemia were denied life-saving blood transfusion here in Port Harcourt by their parents' beliefs, I stood up and fought for them. When young girls were subjected to cruelty of female genital mutilation and child marriage, I raised my voice and fought against it. When the US government HIV program offered care to only a select few of Nigerians in a handful of states, I refused to accept such limitations as the norm. Instead, I championed decentralization and commonization of HIV services, such that everybody, no matter where you lived, where you worked, where you played, could have access to HIV services. And this brought HIV testing and care to where people lived, worked, and even along travel corridors in southwestern Nigeria. With HIV drugs restricted only to people that had CD4 count of less than 200, while unused medications were allowed to expire and be incinerated, I broke the convention. I broke the rules. I ensured that every person diagnosed with HIV across my service sites could access treatment, regardless of their CD4 counts. People fought against it. People said all manner of things against it. And today, I'm glad to announce that it's a national program. To make a change, somebody must get out of the box. And I did that in HIV World. These are some of my publications on what we did. You can just scan the QR codes or go to Google Scholar or PubMed and type my name and the topic, and the articles are all free access. You don't need to pay to read my work. What did I do? During my time at CDC Nigeria, I worked with the government and I worked with CDC and US government to push service delivery sites from just 180 centers to over 1,000 centers in Nigeria. We also moved programs from 12 states to all the 36 states and FCT in just 3 years. As the CEO of Excellence and Fairmind Care Center, I refused to close my doors to fresh graduates in Nigeria. While other organizations were employing those who they believe had experience in programming, in public health services, I and my team took it upon ourselves to employ just fresh graduates who just finished an NYSC and train them, mentor them, and build them and equip them to become experts in public health. Today, many of those same individuals that people rejected are leading public care services across Nigeria and beyond. I have a number of them here in US right now, working for CDC and other organizations. We did not just think outside the box. We destroyed the box. So equity is not a buzzword. For me, it's not a buzzword. It's not a policy slogan or the latest flag to wave. It is a way of life. In Nigeria and around the world, I have worked to embed equity into child health programs. In OVC, for instance, in community participation and involvement, in several health programs, social services, and community systems. Today, therefore, as we focus on equity in healthcare delivery in a changing disease landscape, we must first understand what we really mean by the term equity. Healthcare delivery and changing disease landscape. The pictures you're seeing right now are what we see regularly on Google search on what equity stands for. That equity does not mean equality. Equity is unique. Equity does not equate to having the same services for everybody. But equity gives people the same thing. Sorry, why equality gives people the same thing? Equity ensures that each person gets what they need, when they need it, where they need it, and the way they need it. True equity, therefore, recognizes individuality because everyone have a different need, different expectation, and different challenge. Equity recognizes educational levels of people, their income and cultural beliefs. Equity is so important because it does not mean giving everyone the same level of attention, paying everyone the same rates, or making everyone work the same number of hours. Those may be examples of equality, but friends, they are not equity. So what is health? I know that over the years you have been trained with the WHO Division of Health, which came up in 1948, as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. But to me, although this was visionary, it is neither specific nor operational. That's why in 2018, my team and I developed a new practical and operational definition of health, one designed to guide action, not just aspirational. We defined health as a satisfactory and acceptable state of physical, mental, emotional, economic, and social well-being. We added economic because money is critical to your health. This state should result in maximum productivity, positive contributions, and relevant existence in a degenerating and decaying world, in a changing landscape. It is a state of having the overall physical, mental, emotional, and social ability to add value, not just to oneself, but to the society, resulting in the development of a better and a sustainable world where things work. Where things work. Where people live in harmony and community existence is enhanced. What do we mean by care delivery? Care delivery can be formal or informal. In Nigeria, we have both, and both are vital. Formal care delivery in hospitals, clinics, and even in pharmacies cost money. You have to pay to register for consultations, for drugs, for lab tests, for admissions, for surgeries, for deliveries, and much more. Even sometimes you have to pay to fast track your therapy and services. And in this country where insurance is so far and in between, people have to pay from their pockets. So why a doctor here in Nigeria, I saw people who should not die because they couldn't afford care. Informal, however, care, which is very important in Nigeria, happens through families, friends, and communities, often on a pro bono basis, and remains one of the strongest pillars of care in our society. Finally, what do we mean by changing landscape? When we speak of a changing disease landscape, We are referring to the reality that despite the great victories of the 20th century in controlling infectious diseases, new and reimagined infections continue to challenge us. Alongside these are what we call the triple burden of diseases. First, communicable diseases. The infections that still persist and resurface despite all the drugs that we have because of drug resistance, pathogens like TB, strep, E. coli, 017, and reimagined infections or new emerging diseases like HIV, Ebola, Lassa fever, etc. Then number two, we have the non-communicable diseases like hypertension, diabetes, obesity, cancer, mental health disorders, including stress, anxiety, and depression, which right now is at an epidemic level. And number three, traumas and injuries, from road traffic accidents to conflicts across Nigeria right now, to individuals poisoning themselves with drugs and herbs, to self-harms, to suicide, to intimate partner violence, and for me, including child abuse and female sexual mutilation. We also live in a world today of zero international funding. I'm sure you heard what happened a few months ago when Trump destroyed USAID, stopped most grants, tried to change what happens here at the US with the National Health Institute for Health. And so grants, research grants are all going away. There's a change in landscape. Then national leadership. We have had change of government here in Nigeria at the state level, at Minister of Health level. Leadership matters. But to be able to effectively talk about equity in a changing disease landscape, we must talk about cultural humility. We must understand the culture of the people we tend to serve. Because cultural humility is a lifelong process of self-reflection and self-critique that emphasizes a commitment to learning about other cultures from the perspective of those within them, rather than viewing cultural knowledge as a fixed endpoint. I'm sure my dressing this morning speaks to that directly, actually. In case you don't know where I came from, my dressing will tell you. This is so critical for us to achieve equity in health care system, because different cultures have different problems, different health belief models. There are different levels and different stages of change. And if we do not put this into perspective, we may end up thinking that we are serving them when we are actually hurting them. The triple burden of disease demands everyone plays a significant role, not only in improving the health outcomes, but in protecting populations and ensuring the timely delivery of essential health products and services. To meet this challenge, therefore, friends, we must understand the diverse needs of our diverse population. Over 350 languages, I'm told, over 250 different ethnic nationalities in Nigeria. We must train professionals who respect and understand the cultural expectations of the people they serve. We must practice cultural humility when engaging with individuals from different backgrounds, understanding that they have some cultural assets that we can tap into to provide quality care to them. We must acknowledge historical traumas and lived experiences from Nigerians like the Igbos that shaped people's trust or mistrust or distrust of the Nigerian health system and in Nigeria as a whole. We cannot pretend, friends, that Biafra never happened. Even if we remove history classes, from our schools. We must tell our children the truth, that people were killed, massacred, because they believed in themselves. We must tell people the truth, that hunger was used as a weapon of warfare, and 3 million people died because of it. We must tell people the truth, that people's income was declared useless and their houses taken over by others, and they were given 1 or 2 pence or whatever it was to start life all over again. Cultural humility will help us understand that, respect that, and give everyone their due if we want to achieve equitable system for all. That's why I want to talk to you today, as I begin to round up this presentation, on the 5 P's of public health. Equity in this new era demands that we understand these 5 P's: the people, the problems, the policies, the processes, and the politics. They are the 5 guiding pillars that will shape effective equity action movements. First, people, the heart of public health, friends, is people. Every strategy begins and ends with the community that we serve. Without understanding the people that we serve, their needs and their context, interventions will always fail. 2, problems. The issue we must address, from emerging diseases to systematic barriers or systemic barriers, we must define the problem clearly in the very first step towards, before we can actually attempt to solve them. Policies talk about the rules, laws, and guidelines that govern action. Effective policies can transform health systems. Poor ones, friends, can undermine them. Processes, the systems and methods that turn plans into results. Strong processes ensure that good ideas are implemented efficiently, effectively, sustainably, and with accountability. And finally, politics. This is the power dynamics that shape decision-making. These policies can either accelerate public health progress or restore it. Understanding and navigating political realities of our days and times is essential for real global impacts. So, these, again, are not just words. They are vital in the changing disease landscape, actually in the changing public health landscape. I'm working on a manuscript right now on Public Health 4.0, asking us to run with the new changes that the world is pushing on us. In a changing disease landscape, therefore, the 5 Ps are not just concepts. They constitute a roadmap for action, ensuring that our work is people-centered in this middle, problem-driven, policy-informed, politically astute, and more importantly, process-oriented. This is critical to succeed in public health space in a changing disease landscape. In the end, therefore, equity is and will always be about the people. Every action, every activity, every project undertaken in public health must be people-centered, designed to address real problems through processes that are both effective and efficient. We must never, ever forget that public health is inherently political, and it moves forward or stalls through policies. That means, therefore, that our work cannot be done in isolation. It must be informed by the communities that we serve, strengthened by sound governance, and sustained by our will and the will of the people to act. Let me ask you again this morning, why the war? I told you earlier today that we had to not just only think outside the box in public health services in Nigeria and across the world, we had to destroy the box. Why do we need the war in the first place? As I end this presentation, we must begin to think of how to eliminate, eradicate, and forever destroy every wall hindering people from seeing, from assessing, and from becoming who they want to be. I challenge you, therefore, this morning to find your why and hold onto it. Let your why guide who you desire to become, how you treat the people that you serve, the problems you choose to solve, the policies you have to shape, the processes you improve and run with, and the political space that you want to navigate. Friends, because in public health, equity is not just a goal, it is a commitment. Remember that this commitment starts with you. So what have been my journey? I schooled here at University of Port Harcourt, did my residency here so many years ago, maybe before some of you were even born. Served in Naval Dockyard in Lagos, had private practice in Bethesda Hospital in Abuja, and then opened my own clinic in Kubwana to serve the community because I believe in equity. Then got a job with the Federal Minister of Defense to work at National War College, which is now National Defense College, Abuja. Then came to UNTH Enugu to do my residency and in Benin for my MPH in public health. And then went back and worked with CDC Nigeria, where I expanded the HIV program from 12 states to across the country. I had to enter box to go through my degree everywhere in this country. Then I went to Tanzania as an expatriate and helped them to build their Tanzania Field Epidemiology Training Program. I came back on an invitation from a friend, and founded this EFMC, CFHI, and Modern Health Hospital, and several other initiatives. In 2020, I left Nigeria in the midst of COVID to go to US and became the general health manager of the Climate Force Tribal Systems in Oregon. Then thereafter, I left and came to California, where I served first as a deputy chief of public health in Orange County, a county of about 3.2 million people, controlling COVID and transitioning the system back to business as normal. But because I have always desired to teach, which in my personal program, my personal why, I didn't want to teach for money. I wanted to teach because I love teaching. I want to first make money, see the world, and then teach. I joined full-time faculty position at California State University, Domingo Hills. But before then, I've been teaching here as a visiting professor and also in University of South Wales as a part-time faculty. This has been my journey. The QR code takes you to my LinkedIn page where you see a little bit about me as well. What, friends, is your why? Do you know your why? Have you found your why? Are you running with your why? If you are not, let this speech, let this presentation jumpstart that process, because you cannot be part of the equity movement if you don't know what your own why is. If you don't understand the 5 P's I've mentioned, that P of people, that P of problems, that P of policies, that P of processes, and that P of politics. Once more, Thank you for listening, and have a blessed, enriching, informative, and very empowering conference. God bless you. I'm sure we can take some questions now if you have any.